Hello everyone. So we have a 75-year-old lady. She come to you with for routine checkup. She has fatigue for the last 1 month. Well, her previous medical history is significant for calcified aortic valves and hypertension. Well, she's a 75-year lady and it is a quite common to have a calcified valve in the elderly people. Vital signs are stable except for BP 150/90 and there's a pallor is there. There's a 4/6 systolic ejection murmur in the aortic area which is definitely due to aortic valve. The lab reports are as follows. Hemoglobin level is reduced. MCV is in the normal range. Retic count is increased. LDH is increased, heptoglobin decrease, and fragmented RBCs are there. Most likely cause of the patient anemia is, well, answer is C, macrovascular traumatic hemolysis. Why is so? There are many lab report findings which are suggestive of intravascular hemolytic anemia. There is elevated reticulocyte count. And in fact, this is the feature of any hemolytic anemia. This is a classical finding. If the retic count is not increased, it's not a case of hemolytic anemia. LDH again indicate hemolytic anemia. Decreased heptoglobin level, and this is seen in intravascular hemolytic anemia. Now what happened? This is the blood vessel. Here is the RBC. Okay, this is the RBC. When it ruptures in the blood vessel, this is the blood vessel. When the RBC rupture, HB is released. This HB will combine with heptoglobin. Okay, and this will be removed by the liver. So heptoglobin level are reduced in all types of intravascular hemolytic anemias. Okay, so these two are a feature of any hemolytic anemia, and this is a feature of intravascular hemolytic anemia. Well, now hemolytic anemia is usually macrocytic. Well, because this means RBC size is increased. So the chronic hemolysis can result in iron loss and consequent microcytic anemia later on in such cases, which may not be associated with a decreased retic count. Point to be noted, this I am talking about when we are getting microcytic anemia. But now the question is, why in hemolytic anemia the RBC size is increased? Why they are macrocytic? This is the question. Stop the video, write down the answer. Well, why in hemolytic anemia it is macrocytic? Because due to presence of reticulocytes which are larger than normal RBC. Okay, so they may be macrocytic, or sometimes there may be normocytic also. But the reason is, so why they are macrocytic? Because retics have a bigger size than the normal RBCs. Now in this patient, the most patient history, the most likely cause of hemolysis is mechanical trauma from the calcified aortic valves. This phenomenon is called as macrovascular traumatic hemolysis. Why macrovascular? Because this is happening in the aorta. Okay. Similarly, we can also have a microvascular hemolytic anemia, and this micro is classically seen in condition like HUS, okay, or TTP. In this is a type of microvascular, rather the word they use is microangiopathic hemolytic anemia. Microangiopathic hemolytic anemia. But in case of, if it is happening in the big artery like aorta due to aortic valve calcification we call as macrovascular. So this is also seen in artificial heart valves or markedly calcified valve, which like in our case, the peripheral blood film condition will call as helmet cell or fragmented RBCs. This is a classical question finding. If you are getting the word helmeted RBC or so-called fragmented RBC, you are dealing with some sort of traumatic RBCs. Now look into this. Beautiful picture. This is helmet type of cells are there. Okay. You can see this is so they're also known as schistocyte. This is the other name of helmet cells. Now option A and B are incorrect. Bleeding peptic ulcer and diverticulosis are common cause of microcytic anemia in the elderly person. But they have constant, this is all due to bleeding. The diagnosis cannot be explained by the signs of hemolysis in these patients, like raised LDH, raised retic count, and decreased heptoglobin. They are the feature of hemolysis, not due to bleeding. Well, option D, warm autoantibodies. This is seen in autoimmune hemolytic anemia, and more autoimmune disease are more common in females, and like condition like lymphoid neoplasm or SLE. Okay, like SLE. Then it is characterized by positive Coombs test. In fact, if you are getting Coombs test positive, you are dealing with autoimmune hemolytic anemia. Well, in our case, this is more likely a traumatic type of hemolytic anemia because helmet cells, what we are getting, they are not seen in autoimmune hemolytic anemias. G6PD deficiency is usually causes acute hemolysis, especially taking certain drug like sulfa drug or drug like chloroquine, what we use in malaria. Infection, in fact, it's the most common cause of hemolysis. Usually this is a very commonly asked question. People think about drug. No. Drug is a cause of hemolysis in G6PD, but the most common cause of hemolysis is infection. Can also be there in the fava bean, okay, rather than, so more likely to induce acute hemolysis. Patient typically develop feature manifested at the earlier age. And in our case, the patient is a 75-year lady. This is very uncommon at this age. And it is an X-linked recessive disorder. Okay, X-linked recessive disorder. And that will happen in male, but our patient, as I told you, is an elderly lady. Now, I have a question for you. Stop the video, write down the answer. Sometimes it can occur in female also. How? Stop the video, write down the answer. Remember, the question is, sometimes in G6PD deficiency, hemolysis can occur in female also. Stop the video. Well, a girl child can also suffer from G6PD, hemolysis in G6PD. This is the so-called, the possibility of a daughter being born with one affected X chromosome. Now, we have a term called Lionization. In this, there is one normal X chromosome which is inactivated. As a result, other X chromosome being affected. So let me give you. This is the one X, that 2X. This is normal female. Now we have a female who has got X chromosome, and other one is inactivated. This is inactivated. So we have this is inactive. And this X-link is the one which is carrying the problem of G6PD. So now this will be, and this process is known as lionization. Now this lady can suffer, okay? So this will be significantly reduced level of G6PD to result in clinical disease. The answer to the question is it possible? Yes. Due to what process? Lionization. Golden line to remember, macrovascular hemolysis can cause microcytic anemia in patients with artificial, very interesting line, macrovascular hemolysis. And this is causing why? Because their RBCs are broken down in the circulation, and ultimately that can lead to microcytic anemia. Okay, especially in artificial heart wall and in calcified aortic valve. Like in our case, it is calcified aortic valve. Thank you very much.